Hello, people. Welcome to Count Your Blessing. This is Kuko and Lab. All too soon, we are in the month of October, and in October, we know it's Breast Cancer Awareness Month. So today, we are having a discussion on breast cancer. To help me with the discussion is Dr. Mervin Boache Ajimai. He is a clinical oncologist at the radiotherapy unit of Kolikwu Teaching Hospital. Welcome, Dr. Ajimai.
Thank you very much.
And thank you for having us in your beautiful office.
You're most welcome.
Thank you. So, what is breast cancer?
Breast cancer is abnormal growth in the breasts, which may result out of uncontrolled growth of the cells in the breast. Okay. Majority of the time, we may have different kinds of lesions in the breast that may be abnormal, but all of them are not breast cancer. But when you talk about breast cancer, the abnormal ones are the ones that have the ability to spread to other parts of the body. So we talk something about invasive cancer. That means it can invade and spread to other parts of the body. So that becomes a breast cancer.
Okay. So, how do we get breast cancer?
The exact cause of breast cancer is not known. But what we know is we have something called risk factors.
Okay.
If you have those risk factors, the risk of you developing breast cancer tends to be a little bit higher. Okay. So one, if you being a lady, your risk of getting breast cancer is higher compared to a male.
So, males do get breast cancer.
Males can also get breast cancer.
Really?
But just that the proportion is very low. Like
Okay.
in our environment, like 1 to 2% may probably develop breast cancer.
Wow.
But majority of those who develop breast cancer are females, so that may be a risk factor. Secondly, you look at some maybe estrogen exposure. Now, females that have early menarche tend to develop a relatively high risk compared to those that have menarche at a normal or later stage. Also, if you look at females that have late menopause, they also have a higher risk of developing breast cancer. Also, sometimes if you are considering females that give birth late after 35, there's have been some association with breast cancer. Or if you look at even lifestyle modification, like now a lot of people are becoming obese. Obesity too have been shown to be linked with a little bit of breast cancer. So the risk factors are a lot,
Wow.
but these are just a few that I can mention for now.
So, basically, if I should understand well, some of the things that causes breast cancer are not in our control. For example, the early menarche and then late menopause. We can't do anything about it.
Yes, so if you look at the risk factor, most of the time you have something called, also as you mentioned, let me put it in simple, you that you can control and those you cannot control.
Yeah.
So something can modify them, so time you can modify them. So what you can modify will be checking your weight. But
Okay.
what you cannot modify is like you being a female, you be having early menarche, you being having late menopause. Those things you cannot control. But at least if you know that okay, you are also at risk of developing breast cancer as a result of late pregnancy, you can modify it. It's something you can do. Sometimes
But if the pregnancy is not coming, it's
yeah,
not our
that's why I
fault.
say some of the things you may, so it's like a may. Yeah. But you know now because of like modernization, a lot of people are like concentrating more on education. So a lot of women are rather giving birth late. So the first pregnancy, if it's a little bit late, it also tends to increase your risk a little. And also maybe if you have a family history, you can't do nothing
Anything
about
about
my
it.
family history. There's something like the BRCA mutation, all these things you cannot do anything about them.
Wow. So, how do we then detect that we maybe have symptoms, or is there anything that we can help us check that, like malaria? If you are having malaria, maybe you have a headache, you have chills, like that.
So to detect breast cancer, okay, the presentation tends to be in three folds. One, either you are going through a screening program that it will be detected. Sometimes because some have a strong family history or genetic mutation in the family, they will be under surveillance. So that also will help you to detect it early. And other times, a lot of patients, especially in our environment, present as a result of symptoms. Maybe they've noticed a lump in their breast, they've noticed changes in their breast, pain in their breast, maybe the breast is becoming bigger or the skin of the breast is changing. All these may drive them to seek attention. So that will be the first step to presentation. Once the patient presents, that's when you look at how you are going to diagnose. And to diagnose it, you need to go through a good examination. So we talk about something called clinical breast examination. Sometimes people try examine their breast at home, but may probably pick something up. You still need a doctor or someone who has experience to really confirm it, because sometimes maybe depending on how you are palpating the breast, you'll be able to pick something which may be normal, or probably because you are holding tissue in between tissues. So you need a clinical breast examination to be done. Once you get a breast examination done, the next thing is to have imaging done. So either you're going to do a mammogram, you're going to do an ultrasound. In some cases, when it's an those under surveillance, you may even consider doing MRI, because that will be able to pick it up early. So if you have any abnormality on clinical breast examination or on your imaging, then you go ahead to biopsy it, because the only thing that can let you know that okay, patient has breast cancer is a biopsy. All that we are doing just try and it suspects breast cancer, but what confirms the breast cancer is the biopsy. So any lesion in the breast, whether it's even they think it's benign or they have to still be biopsy just to confirm that okay, you're dealing with a benign lesion or you're dealing with a malignant lesion, or that's breast cancer in this case.
Wow, thank you. You said you talked about self screening. How do you do it?
So the best time to do a self screening is about mostly after 5 to 8 days into your menses.
5 to 8 days into your
Some
menses.
even extend to like 10 days, because majority of the time the issue is when you're menstruating there is breast changes that go along with it. So maybe after your menses, at least those changes come down, so you'll be able to feel the normal breast. Also, when you're 14 days after, like if you 14 days into your menses, you'll be ovulating. Just before and during ovulation to their breast changes. So you have that narrow period that will be able to at least have a good feel of your breast. So that's when the ideal time you are supposed to do your breast examination. And in doing the breast examination, there are a lot of ways to go about with it. But the basic thing is you should be able to know your breast and try to examine the whole breast. Okay, so you should look at your breast like it's standing, but it's not like it's not falling down on your chest wall. So it's more like it's just standing upright on your chest wall.
That means you should lie down.
It depends on, you can hold it, you can lie down,
Okay.
whichever way that you feel more comfortable with. But so you just by anytime you examine your breast, it should be like okay, it's just standing upright on the chest wall. And if you want to go around the whole breast, some will try and go through a circular motion from outside till they get to the nipple. Some will try and divide their breast into four and try and examine all the quadrants. So it depends how well you feel, or which one is comfortable to you. That's what you're going for. And when you're palpating, you need to press the breast tissue against the chest wall. So you shouldn't hold the breast tissue. And
Okay.
as much as possible, you use this part of your fingers. You shouldn't use the tip,
That's it.
because if you use the
Okay.
tip, sometimes it may feel lumpy. But if you're using the power cord going towards the center, at least you'll be able to feel the lump if there is anything like that.
But the tissue in the breast, like you said. So how do you feel it? How would you know the difference?
So that's why if you are pressing the tissue to the chest wall, at least if it's directly to the chest wall, if there's anything, you'll be able to feel that okay, there's a normal and there's something funny in between. So that's why you need to know how your breast examination, self breast examination is really recommended. Because if you've been doing your self breast examination every month or,
Every month.
or frequently, you know that okay, this is how my normal breast feels. So once you start feeling something funny in between, you can easily tell that okay, that's unusual. So you may probably seek help for it to be evaluated.
Wow, thank you. Um, so if I come to the hospital, let's say a patient walks in, a screen, and they notice she has breast cancer, what's the next stage?
So once you've been diagnosed with breast cancer, the next thing is to stage the patient. Okay. So you probably have to do other imaging to see is that because whatever you are doing, your examination, your by yourself, everything is limited to where the breast is. You have to make sure has the cancer spread, or just limited to just the breast. Because the mammogram ultrasound just look at the breast and your armpit, your axilla. So you do your so ideally you are supposed to do CT scan because that one will helps you to be able to identify pathologies or distant disease very well. But unfortunately, in our environment, because of costs, mostly we do with chest X-ray or ultrasound. But the best thing is to do CT scan of your chest and abdomen. Okay, so maybe you do your chest X-ray ultrasound or CT scan to be sure whether the disease has spread or have not spread. After that has been done, your oncologist or whoever is seeing you, or your surgeon will probably will discuss at something called multidisciplinary team meeting. In that meeting, we have different specialists from different specialties. So you may probably have an oncologist there, a surgeon there, radiologist there. You may have, if they need to be a psychologist may be there, the pathologist will be there. We have a lot of people, the nurse navigator who will help you maybe navigate through your treatment also there. And so depending on what the specialties we need, we bring them on board. So during the multidisciplinary team meeting, the MDT, that's where the decision will be made based on your stage. Are we treating you with cure? We are treating you with palliative intent. So those decisions will be made, and we develop a treatment plan for you. Because if you understand your treatment plan from the onset, it makes it easier for you to follow. And once those treatment plan have been developed, that's where your nurse navigator also will probably go through with you to be able to understand it well. Because after it has been developed, your oncologist or your surgeon will speak to you just to understand that okay, we are doing A because of A, B, C, D. Because everything is boiled down to or is backed by research. So you need to understand why every decision is being made. And in so doing, it makes it easier for you to also go through the treatment, knowing that the best decision was made for you. Because sometimes different patients, even with the same stage, may have different treatment regimen because of one or two things. So everything has to be explained well for you so that you understand what's going on.
So it's not like the patient gets cancer and the next thing is they have to maybe do a mastectomy or
No. So the treatment options vary. So we need to really sit down and because your stage will determine which treatment you are going in for. We look at the pathological findings. That also will help us know what we are doing because now even though we have breast cancer, in breast cancer we have different types of breast cancer. And even with that, we tend to even the different type of breast cancer. We have something called immunohistochemistry or the molecular subtypes. The molecular subtypes also will let you know how each particular breast cancer is behaving. So all will give you a big information about what to do. So when we are coming up with the treatments, we don't really just get up and say we are treating. We need to understand, okay, this particular person has the nature of breast cancer in the person like, and based on that, we develop the treatment tailored to that particular person. Yes. So even with the treatment option, mastectomy is not the only option when it comes to like surgical intervention. Mostly there's the opportunity for you to have breast conserving therapy. In the breast conserving therapy, we take the lump out and leave the rest of the breast in situ. Okay. So for you to go through breast conserving therapy, you need to present early. Because if, as I mentioned, you are taking the lump with normal tissue. So if you don't present early and your whole breast is filled with tumor, it's difficult for us to conserve your breast. Or in case you are going to conserve the breast and just going to, it will be left with like let's say one fourth of your breast. It won't be so because everything that we are doing is because of the one apart from the social culture effects, also is the cosmetic effects. Okay. So in that case, if it's not available, then the next option to look out is the mastectomy. And mastectomy is done we do mastectomy because we know that one will be best for you. But even in our environment now, there's the option of breast reconstruction. So once the mastectomy that have been done, we can reconstruct another breast for you so that you be able to have the cosmetic effect that you need.
That's nice to know. Any advice for us?
So the best thing when it comes to breast cancer is early detection. So as we've heard over and over that early detection saves lives. So we need to report very early. because for you to be able to have a higher ability to survive, detecting the breast cancer early helps very well. And also, even with the early detection, not only does it improve survival, but also helps you to go through less treatment. Also helps you to conserve your breast, which most I think the fear of mastectomy is one very big factor that
Yeah.
a lot of people fear when it comes to breast cancer. So you'll be able to conserve your breast and go through your treatment very well. Sometimes too, when it comes to breast cancer, a lot of people fear chemotherapy. Okay, but now there'll be a lot of advancement in administering chemotherapy. So even with that now, the side effects a lot of people fear are not really being seen, even though they are side effects. And also, even if you report very early, sometimes you may not even need chemotherapy. So even though chemotherapy, there's this stigma with chemotherapy. It's not really as bad as a lot of people let it seem like. Yeah.
So, do you have to necessarily go through chemo and mastectomy at the same time, or it can be different?
So that's why your treatment plan has to be developed. So
Comes to treatment
when
plan.
it comes to the treatment plan, always you need a surgical intervention for if you are managing with the intention of cure, you need a surgical procedure to be done, whether mastectomy or breast conserving surgery. Okay, and you need systemic therapy. Okay. So the systemic therapy also will depend on the treatment plan because now there are other therapy that may be given in terms of systemic therapy. We have the chemotherapy, we have the targeted therapy, hormonal therapy, immunotherapy. So everything will then be developed for you to know that okay, this is the systemic therapy that you're going through. But at least most patients may need chemotherapy. But if you present very early, that's where sometimes there will be no need for chemotherapy.
Is there any help for people living with breast cancer?
So when it
Because
comes
everything you are talking about comes to money, and in this country, money is really hard to.
So it's a little bit difficult when it comes to management of breast cancer one because of the facts. But now at least some of the treatment modalities are on insurance. Maybe
That's good.
even like the surgical, you may probably pay some, but at least insurance may make it up for some of them. The chemotherapies are on insurance, and some of the targeted therapy and the hormonal therapy on insurance. But at least when it comes to radiotherapy, you need to pay out of pocket. So at least some of them are covered under insurance. When it comes to the treatment, it's not like you have to pay everything at a go before you go through the treatment.
Okay.
Because once the plan is developed for you, you know that okay, I'm supposed to start with a surgery. So maybe insurance will cover it for this. I need to pay X, so you make an arrangement for it. After surgery, chemo. During the chemo, maybe I'll be paying X amount of CD over this period of time. You're making a plan for it. After chemo, radiotherapy. Maybe during the radiotherapy, there's a plan for radiotherapy. So even though the is a capital intensive, it's spread over time. It's not really a one-time payment.
I see. This is exhausting. But do you mentioned that there's a team before the patient is put on the treatment, and you mentioned a psychologist. Does the psychologist only talk to the patient, or they talk to the whole family, at least the immediate people who will be tending to the patient? Because I think sometimes they also feel burdened.
So at least once it depends on the support, and a lot of times maybe the patient ideally it targets the patient and the family. Okay, and apart from just the psychologist, I talked to you about the navigators. So now we have in our environment we have the nurse navigator, then also we have the navigators who are survivors. So sometimes they're able to share their experience with the patients. Some of them they're able to maybe tell their relatives about one or two things. But at least the patient is the center of things. So that's where most of the control, most of the decisions are being made. And when the psychologist talks to a patient, and probably the patient he knows that the patient has family issues who need to be addressed. They see as much as possible to bring the family together. But sometimes if the family members are also around during the gathering, they see how to also consult both the patient and the family members. So it all depends on the time you refer to the psychologist who came along with the psychologist. And based on that, you identify and see how best you will help the patient out.
Oh, thank you so much this morning. We've taken a lot of your time, and I'm grateful that you avail yourself for us to have this conversation.
You're welcome.
People, you've heard it all. Breast cancer is not an easy thing. So let's create the awareness. We are in the breast cancer month. At least invite 5 people and talk to them and tell them to go and get screened so that they can detect early and then they can save their breasts. Thank you for watching and have a wonderful time. Bye.